I hope that you can see me and hear me. Hello. I was talking and my computer was frozen, so I don't know if you heard anything, but we're going to start talking about range of motion. My computer is crazy slow, so I'm sorry if you already heard me welcome you, but um, it's going to take a while to go to the next slide, evidently, because I keep pushing. Okay, start out with some definitions. So range of motion is the amount of movement of a joint or a body segment. Functional excursion is the distance a muscle is capable of shortening after it has been fully lengthened. Shortening after it's been fully lengthened. We have active and passive insufficiency. Both of those are talking about two joint muscles, with active insufficiency being the point where it can shorten no more. So for the biceps, if your elbow is fully flexed and then you try and fully flex your shoulder, you can't fully flex your shoulder because of the shortened biceps that is passing both of those joints. And so that would be an example of active insufficiency, that a two joint muscle is moving at both the joints simultaneously, and the shortening, it's now at its most shortened state, and it can't produce any more contraction. The passive insufficiency is the point where the muscle can no longer elongate. So an example of that is your hamstring. So if you keep your legs straight and your knee straight, and you flex your hip, so like you're lifting your leg up, then you cannot get full hip flexion because the hamstring is at its maximal length. Remember, it passes both the knee and the hip. It's at its maximal length and it's blocking that movement. So in order to get full hip flexion, you would have to then bend the knee. So that's an example of passive insufficiency. So with active insufficiency, we're talking about the agonist. It's the point where it's so short it can't contract any further. With passive, we're talking about the antagonist. So in this example, if we're severely limited with shoulder flexion when our elbow is flexed, then it could be that the tricep is too short and it's at its fully lengthened position, that it's really tight and has a lot of tone. So that's active versus passive insufficiency. Factors that decrease range of motion. There could be systemic factors like neurological factors or musculoskeletal. There could be some joint integrity problems. Arthrokinematics, remember, are your joint movements. It could be surgery, traumatic injury, inactivity, or immobility. All of those could limit your range of motion. Types of range of motion, we have passive, active, and active assistive. So passive range of motion is produced by an external force. This right arm is just hanging out, riding along. The left arm is pulling it up. Active range of motion, the muscles are producing the force. Muscles contract and they pull a bone. There's no external force. With active assistive, it's kind of a combination of both. The muscle is activated and produces force, and an external force helps that along. So typically that's with somebody who's kind of in between the passive and active range of motion stage. They're trying to get full range. That you want them to use their muscle as much as possible, but they get kind of stuck before full range, and then they push themselves the last few degrees. That is active assistive range of motion. All right, these examples you guys can look at, you can do on your own, or you can skip through. This is if we were in class together. All right, indications for passive range of motion. If there is a acute inflamed tissue, if active motion would be detrimental to the healing process, so remember right after surgery, typically the first 2 to 6 days, if they contract the muscle that's just recently been tied back in place, it could break through those stitches before it's healed enough. If a patient's not able or not supposed to actively move a body segment, like maybe they had a spinal cord injury and they're not getting any nerve impulses to allow them to move, or maybe they're not supposed to because that movement could damage healing tissues. All of those would be indications that the patient needs passive range of motion. Some of the goals: to decrease immobilization complications like contractures, to maintain joint and connective tissue mobility. You know, if you sit in one position for a long time, you're going to get stuck in that position. minimize formation of contractures, maintain mechanical elasticity of the muscles, assist circulation and vascular dynamics, enhance synovial movement for cartilage, nutrition, diffusion of materials. So that's just saying get nutrients in and out of the joint so that movement can help push some of the inflammation out and allow the new good products to come in and feed the joint. It can decrease or inhibit pain, assist with healing process after surgery. Remember, after an injury, scar tissue begins to just sporadically lay down, and if you're moving the muscle even passively, it can help the scar tissue realign properly. But if you are not, then it will just stay in kind of that clump, and then it will actually restrict your movement and help maintain the patient's awareness of movement. So all of these are goals of passive range of motion. You can also use it to prepare somebody for stretching, to teach them the appropriate movement before they do active range of motion, or to inspect their joint integrity. So looking at infills and kind of getting a feel for how the joint's moving. To see where the limitation of movement across the joint is, to check soft tissue elasticity, and to check for muscle flexibility. So you can use it as an assessment or to teach and prepare for the next thing that you're doing. Okay. Limitations. It cannot prevent muscle atrophy. It doesn't matter how much you passively move a muscle, they're not activating any muscles, and so their muscle is not going to maintain its strength. It's definitely not going to get stronger, and over time it would atrophy if all you're doing is passive movement. It cannot increase strength. It cannot increase circulation, and primarily they're talking about new blood vessels forming. So whenever you're working out and you're pumping more blood to an area, more circulation is shunted towards that area. But if all of you're doing is relaxing and they're moving, although the joint is getting more nutrition, the muscles themselves are not getting improved circulation. And it doesn't engage the muscle actively, which is the exact definition of passive range of motion. All right, active and active assistive range of motion indications. When a patient is unable to move through their desired range, especially against gravity, then active or active assistive range of motion would be indicated. Definitely not resistance training. We like a patient to be able to move through their full range before they start adding weights. If they can't do the range of motion against gravity without weight, there's no reason to add any resistance. If their muscles are weak, you could do active range of motion or active assistive. If one segment is immobilized, then you could mobilize the segments above and below. For example, if they had a shoulder surgery, you may give them a ball to squeeze, or you may have them do some elbow flexion and extension just to keep all that loose. You may have them do some neck stretches to keep all that loose. Aerobic conditioning program to prepare for something, doing active movements in order to get the blood flowing and preparing for a workout, and then to relieve stress from prolonged posture. So if you've been sitting here watching your computer for a long time, doing some active motion might help you relieve some stress on certain body parts depending on how you're sitting or standing. More goals are to maintain elasticity and contractility of muscles targeted. So if you are extremely buff, then just doing active motion is not going to be enough to maintain all of your strength, but to allow the muscles to still function correctly, doing the active range of motion will be helpful. To provide sensory feedback from those contracting muscles, to provide bone and joint tissue stimulation, increase circulation and prevent thrombus. Remember, that's a blood clot, so prevent a blood clot from forming. Develop coordination and motor skills for functional activities. Contraindications and precautions. This is of active range of motion and active assistive range of motion. If active range of motion is going to be detrimental to the healing process, we don't do either of those, only passive. If a patient's not able or not supposed to move actively, basically same thing. Precautions if the movement should occur within limits of pain-free motion. Okay. I put a caveat on this. Some people have no pain-free motion. They're already in pain at rest. So I would say with people like that, try not to increase their pain so much that it's excruciating or unbearable, or that they're saying it's a stabbing pain. We like to avoid stabbing pains, discomfort, or stretching pains. We can push through, but stabbing pains are signs of tissue damage. Closely monitor the symptoms for patients with cardiac impairments, especially if they've had any type of lead that goes through the arm and into the heart. Then range of motion might be contraindicated for that arm. So you just kind of have to look and see for that individual patient what is appropriate. All right. Screening and treatment. So we can use range of motion to screen and to treat. We can determine the level of range of motion, determine the normative values. We can account for tight muscles that have unique attachments. I said see below because I have listed on the PowerPoint below some muscles that have unique attachments. So make sure you're taking that into consideration when you're going through somebody's range of motion. Make sure you determine the safe amount of motion, decide the pattern of motion that will meet that patient's specific goals. And then monitor their response throughout, see if it seems like it's painful or if they seem like they're comfortable or not. Document and communicate the findings. This looks limited, this looks increased, whatever you find, and then reevaluate and modify as appropriate. So make sure that you're assessing throughout to determine what is causing this limitation. Are they tight? Are they afraid? Are they in pain and they're kind of blocking the movement? Or is there a true limitation there? Infills, that's where this all comes in. Infill is the type of resistance that is felt when passively moving a joint through the end range of motion. So if it's my elbow and I just move it all the way to the end, at some point there is a stop. And I assess and say, how does that stop feel? And depending on how it feels can give me some insight to what is stopping that. So the infills that are most commonly used are soft, firm, hard, which can also be called bony, empty, or spring block. And we'll go through each of those. With a soft infill, that is when tissue, I don't know if I accidentally deleted the word tissue, I'm sorry, tissue is being compressed and it stops further movement. So for example, knee flexion. When you bend your knee fully, the gastroc is in the way and you can't bend it anymore. That would be a soft infill. If you have a really big bulging biceps, then you could also have, most likely you're going to have a soft infill with elbow flexion as well. Your biceps is going to get in the way. A firm infill, that is when tension in the joint capsule and ligament are limiting the movement. Okay, so an example would be hip extension or shoulder internal or external rotation. And when you feel a firm infill, that is when we know that joint mobilizations are most indicated. So a firm infill would be a tight capsule or ligaments, and that's when we would do some joint mobilizations to try and stretch. Typically the capsule is what we're targeting, in order to allow the more normalized movement in the joint. That would be with a firm infill. With a hard or a bony infill, that is when it is an unyielding sensation. It's just a hard stop. It's typically bone-to-bone interaction, bone-on-bone connection. And an example would be elbow extension. When you extend your elbow, you get to a point where two bones are meeting, and there's just a hard stop or a bony stop. With an empty infill, it can be caused by one of two things. Either pain is limiting the movement, so you start to move and you don't get to a stopping point, but they're like, ow, ow, it's too much, or they start to tense up and you can't go any further because they're just so tense. That would be considered an empty infill, and we can also document it as pain is the limiting factor. Or no restriction is felt. You don't get to a stopping point. You get to the normal range and there's not a stop. Sometimes you may feel a little bit of protective muscle activation around it, but otherwise there's no true stop. So it could be because their ligaments are damaged or they have significant hypermobility. So like in this example, if you were mobilizing the thumb, some significant hypermobility there. If you mobilize this knee after this injury, there would be some hypermobility there from tendon and ligament tears. All of those are empty infills, and empty infill is always signifies a problem. It's never normal. There's no joint in the body that should have an empty infill. There should be something, capsule, ligament, bone, or muscle, that stops the movement. And if there's not, that's abnormal. Spring block infill is when you have a catch in mid-range. So typically it's either a meniscus tear or a labrum tear. Both of those are cartilage. The meniscus is in the knee, the labrum's in the hip. And if you are doing a McMurray's test to test for a torn meniscus, then you might feel the catch, or the patient might feel the catch. You may not. Sometimes you hear a clicking or something that can also cue you into that. But if you're going through range and you're like, oh, there's a catch there, but I can go further, that's called a spring block infill, and that signifies a tear in the cartilage or damage to the cartilage. All right, so application, patient preparation. First, before you start ranging somebody, describe what you're going to do. Describe the intervention, what goals you're trying to meet. I felt it coming on, sorry. And then free the area from restrictions. So if you need to have them put a gown on or change into shorts or something like that, then you can take off a brace, something like that. But drape the patient, make sure that they're comfortable. And depending on if it's a male versus female encounter, or if they're from certain cultures where maybe they're a little bit more modest or something, just take all of that into consideration when you're thinking about draping a patient. I would always suggest draping unless they say otherwise. But even in that situation, if it's a private part, drape, because you could be liable if they say, oh, he didn't drape me, even though they're telling you not to. Position them for good alignment and stabilization, and position yourself for good body alignment, so that you're in a good position to use good body mechanics. Control the movement, grasping around the joint. Typically we will stabilize just proximal to the joint we're mobilizing, and then we'll have a hand pretty close to the joint surface in order to mobilize. Support the areas of poor structural integrity. If there's some place that's really hypermobile or really flexible or weak or whatnot, make sure you're supporting that. Move the segment through a pain-free range to the point of resistance. And I say if possible, because again, some people are in pain just at rest and they're going to have pain the whole time, but try not to increase the pain significantly. You could say at the beginning, if your pain gets a lot higher, let me know so that I can stop. And then you move to the point of resistance. We don't typically push past the resistance, just kind of move to resistance and determine what does that resistance feel like. In some instances, like let's say after a knee surgery, when you're really trying to gain motion, we may push into that resistance. Perform motion smoothly and slowly. If you start to move fast, remember that stretch reflex is elicited. So if you do a quick, sudden movement on a body part, then there's a reflex at the level of the spinal cord that causes that muscle to contract against it. Remember, we use it in PNF to help us go the way we want. So we do a fast action in the opposite direction and then a slow action in the direction we want to go, so that we activate the muscle that's going to be helping us move in that direction, and we kind of inhibit the opposite. But if you're wanting to do shoulder flexion and you quickly flex, their natural instinct is to push down against you. It's not something they're trying to do. It's just a reflex. So slow, smooth movement is key with range of motion. but typically we do a little bit different based on the body part, based on the patient and their diagnosis. So it may even change from one session to another depending on what their needs are. More application, movement of the segment by a therapist or mechanical device. That's passive range of motion. There's no active contraction. The muscle should be through a pain-free-ish range when possible. And remember, passive range of motion does not increase muscle strength. You get no help for muscle contractions or strength passively. If all you're doing is sitting there and there's a machine moving your arms up and down, don't expect to get any stronger, but you can expect your motion to be maintained. With active range of motion specifically, we typically will demonstrate the motion using passive range of motion, show them what we want, then ask the patient to perform the motion, and then if they need help, provide some assistance to make it either more smooth, or if they're weak, to give that extra push at the end, which would then become active assistive range of motion. And then move throughout their available range of motion. Let's say that you gain some motion throughout a treatment session. If they use that motion and they continue to move through that full range of motion, then the next time they come, most likely you'll be able to start kind of where you left off the treatment before. If they do not, then you may be starting all over every session. It's going to be really hard to gain range of motion. And then provide feedback throughout about their form. So whether it's their first time or their 30th time, make sure you're telling them thumb up, shoulders down, relax the shoulder as you lift up, don't let it come up to your ear, different cues like that as they're going through to make sure they have good form and they're not using compensatory muscles. With active assistive range of motion, similar to active, but you typically have either a therapist or the patient's own arm or a device to help you go a little bit further. It's patient-led. You could use a wand or TheraBar. You could use like a wall climbing with your fingers, ball rolling up and down. You could use some pulleys, which are questionable in certain circumstances because they could cause some impingement. A skateboard or a powder board, reciprocal exercise unit. There's a lot of devices you could use for active assistive range of motion. What we do is we educate the patient. We may show them the exercise. We certainly watch them perform it, make sure that it's safe, give them feedback, make sure that the equipment they're using is not hazardous. I think there was a student using a broom to show us one time and the broom head fell off. We don't want anybody hit with a broom head, so just make sure equipment isn't faulty. And then provide drawings and clear guidelines, especially if you're sending this home as part of the home exercise program. You want to have pictures so that they can mimic correctly what you would like for them to do, the movement your goal is to achieve. Continuous passive continuous passive motion, CPM. This is a machine that you put somebody's arm or leg in, and it does continuous slow motion for hours at a time. So it's passive motion performed by a mechanical device where they slowly and continuously go through a controlled range. So typically it's used after surgery. Typically it's put on one of the first few days after surgery and maybe used up to a week. And it is to help decrease the creation of scar tissue and to help increase the movement without creating or placing stress on the joint itself. Keep the blood flowing, things like that as well. Prevents development of adhesions and contractures, stimulates healing of tendons, ligaments, enhances healing of incisions, increases synovial fluid lubrication. Remember, that's the fluid that gives nutrients to the joint. Prevents degrading effects of immobilization, quicker return to range of motion, and decreased postoperative pain. Remember, when you sit still, more inflammation sets in, you get more stiff, more limited motion, and more pain. So there are great benefits to moving, even if the movement is strictly passive. Some of the guidelines: it needs to be applied typically immediately after surgery, and you continue to apply it apply it for several hours a day. Often it's like, I think 4 to 8 hours. I have it below. And for 2 to 6 days after surgery. So up to a week is kind of the longest we typically use the CPM machine. You can set in there the arc of motion and the rate of motion. Typically, we're going to go, let me see, I have the guidelines written at the bottom, but my computer's going to take forever to escape. Okay. Let's see. Arc of motion's predetermined, typically 20 to 30 degrees, and then you progress them by 10 to 15 degrees per day as tolerated. That will be written in the notes, so do not progress on your own. I'll make sure that it's okay by the surgeon to progress. The rate of motion is typically 1 cycle every 45 seconds to 2 minutes. So no faster than 45 seconds, no slower than 2 minutes, so that it's continuously moving through a slow rate. Duration of the machine, 4 to 8 hours, like I said, is typically what we're seeing the most gains. And then devices are often portable, they're often battery operated, and sometimes the patient can do some type of functional activity while they're in it. Of course, they're definitely not going to be able to like get up and walk and stuff, but maybe knit. I don't know. And then the physical therapy that is given when a patient is using a CPM machine is during their off times. So you take it off for physical therapy, and then you put it back on for continued passive motion. So a CPM machine. Okay, these next slides are just kind of for your reference, and this is kind of helping you understand the capsular patterns. So capsular patterns mean that you see typical patterns specific to each joint of movement limitations that tell you the capsule is what's limiting that movement. Remember, we talked about that firm infill, and when you feel that, you also typically will notice that certain movements are limited in a specific pattern consistent with that capsule being tight. So for example, with the cervical spine, side flexion and rotation are the most limited, and then extension is next. So it's not as limited as flexion and rotation. So that's kind of how you read that chart. The things listed first are what's most limited, the range of motion that's most limited, and then the things listed after that are the things that are less affected. So you can look through these in your own time just to get used to the capsular patterns. And then with non-capsular patterns, the limitation in the joint does not follow these patterns. So anything that's outside of these patterns would be non-capsular. The restriction is coming from something other than the joint capsule. That's why they're non-capsular. It could be a loose body. It could be an adhesion that didn't affect the capsule. It could be some scar tissue, anything like that. And that would be a non-capsular pattern. And that just helps you understand how to go forward. Now, if it is a capsular pattern, typically joint mobilizations are recommended. Of course, you would have to look at the indications and contraindications for those specific joint mobilizations. But if it's a non-capsular pattern, most likely joint mobilizations will not be recommended. All right, that is it for today's lecture. We will be practicing range of motion in lab, so please reach out to me if you have any questions, and I will see you in lab.